Good afternoon, everyone. I'm Matthieu Schmidt. I'm assistant professor in the medical ICU in La Pitié-Salpêtrière Hospital in Paris, and we have 12 minutes together to talk about mechanical ventilation for ARDS patient during VV ECMO. So here are my disclosures. So when we discovered the concept of baby lung 2 decades ago, what a key message which was important and which is also very important in the ECMO field is that the smaller the baby lung, the greater is the potential for unsafe mechanical ventilation. So clearly this is our patient, our ECMO patient. He has a very small baby lung, so clearly we need to pay attention to mechanical ventilation during the ECMO run. So we have to find a way to treat the baby lung gently, and we need to find a way to decrease all mechanism involved in ventilator-induced lung injury by reducing atelectatic trauma, by reducing barotrauma, volute trauma. It may decrease at the end the biotrauma, and maybe we may have some impact on the myotrauma by promoting spontaneous ventilation. And we need to keep in mind that the principles of VV ECMO is, first of all, to replace pulmonary function to ensure oxygenation and carbon dioxide removal, but it's one of the key functions is to allow the lung to rest and to allow healing of the lung. So by doing that, to achieve that goal, these goals, we need to decrease the mechanical ventilation, to employ ultra-protective ventilation by decreasing the mechanical power, so the energy promoted by the mechanical ventilation. And this has been shown in this large cohort, international cohort, showing that when you start ECMO, in most center markedly reduce mechanical ventilation, so the mechanical power transmit by mechanical ventilation is reduced by 75%. So you have a reduction of 75% of mechanical power. And if we look at the mechanical power equation, we are seeing that there is 3 components, 2 main ones. The first of all is the volume, which is a very important component of the mechanical power. So by reducing the tidal volume, and by this way to reducing the plateau pressure, you see that in that experience, when they reduce the plateau pressure, targeting a plateau pressure at 25 by reducing the tidal volume and by applying carbon dioxide removal, when they did a bronchoalveolar lavage before and 72 hours after, you see that all the cytokines have markedly decreased due to the reduction of the tidal volume and the plateau pressure. And from a clinical point of view, it was suggested in this randomized control trial, the X-TRAVEN study, comparing 2 mechanical ventilation strategy, one strategy with a conventional 6 ml per kilogram ideal body weight versus a reduction of the tidal volume up to 3 ml per kilogram with a combination with extracorporeal CO2 removal. And when you look in all patients, clearly they didn't find any difference in terms of ventilator-free days at day 28 or day 60 between the 2 groups. But when you focus on the most severe group, so the group with a PF ratio below 150, you see a very strong signal saying that maybe for this very severe patient, it may be useful and benefit to reduce the tidal volume to increase the ventilator-free days. And regarding the volume, if you look at what are the practices on VV ECMO in a large international cohort center, you see that before ECMO, so the red line, you see that targeting a tidal volume at lower 4 milliliter per kilogram was done in only 8% before ECMO, and this percentage increased up to 65% of the ECMO patient receive a tidal volume below 4 ml per kilogram. The second component is the respiratory rate, which is also very important in the energy transmitted into the lung. And for that, to support a reduction of the respiratory rate, we have this animal study, which compare two strategies. So the only difference between this strategy and that one was the reduction of the respiratory rate. And to be sure that the pH, PCO2 was comparable in both groups, they combine it with extracorporeal CO2 removal. So in this animal study, the only difference between the two groups of animals was the reduction of the respiratory rate with exactly the same tidal volume, and the respiratory rate was divided by 2. You see that when you look into the bronchoalveolar lavage, you see quite impressive reduction in the bronchoalveolar lavage, reduction of the cytokines, inflammatory cytokines. It was also the same in the plasma cytokines. So maybe the biotrauma was reduced in the group with lower respiratory rate. And when you look at the proportion of mechanical power reduction, when you look into the LifeGuard study was an international cohort, you see that the mechanical power was markedly reduced, but you see that the respiratory rate was 55% of the part of the mechanical power reduction. If you look at the Eolia trial, it was quite the same proportion. Reduction of tidal volume was part of 43% of the mechanical power reduction, whereas respiratory rate reduction was count for 57% reduction. So obviously, if we reduce the tidal volume lower than 6 milliliter per kilogram with a target below 4 milliliter per kilogram, you may cause pulmonary derecruitment. So to prevent for that, you need to increase your PEEP level. And to support that, there are not so strong data, but we have this data showing that the high level of PEEP was a protective factor against mortality in a very large retrospective international multicenter study. So if I reduce my plateau pressure by reducing my tidal volume, if I increase my PEEP, I will decrease at the end my driving pressure. And we know this relationship between relative risk of death in the hospital and the driving pressure. So the higher the driving pressure, the higher the relative risk. And with ECMO, you can safely decrease the mechanical power, the driving pressure, sorry. And clearly on ECMO, we will target a driving pressure below 15, because based on that landmark study, you see that the relative risk of mortality was below 1 when the driving pressure was below 15. And it was also demonstrated in this large meta-analysis with individual patient data, showing that if you compare patients who died or those who survived on ECMO, you see that the survivors had a lower driving pressure during the first 3 days on ECMO. And driving pressure was the only one risk factor associated with mortality. So the higher the driving pressure on ECMO, the higher the mortality. And in practice, in clinical practice, what do the centers, the experienced centers? If you look at the driving pressure, you see that most of the time they target driving pressure below 15. And you see that a driving pressure below 15 before ECMO was in only 34% of center, and it raised up to 68% of center who got a driving pressure below 15. So clearly, it's a very interesting field with still numerous questions. And I will just stress out a few points. which are interesting and which might be useful to enhance ventilator lung protection and to try to decrease ventilator-induced lung injury. So we know the benefit of proning to prevent ventilator-induced lung injuries. So what about proning on ECMO? It might be an interesting way to enhance lung protection. And in small retrospective study, it was associated with a signal saying that it may speed up the weaning of VV ECMO. So clearly, for now, there is no strong data to support current prone positioning on ECMO, but clearly it's a track to follow. Its future research expected to know if there is any benefit to prone your patient on ECMO to reduce ventilator-induced lung injury. Another key question is to know if there is if it's interesting to decrease further mechanical ventilation on ECMO until apneic ventilation. In this animal study, it showed some less histological lesion of ventilator-induced lung injury. So maybe an interesting thing. Clearly, it's animal study, so we need to have a clinical study in human to support apneic ventilation on ECMO. Another thing is to try to individualize your ECMO your mechanical ventilation setting on ECMO, and for that, a few studies have tried to investigate the use of tools to set the mechanical ventilation. So electrical impedance tomography has been used, and more recently, an interesting study from China suggesting a better prognosis and a lower mechanical power at the end on ECMO if you used transpulmonary pressure in this severe patient. So clearly, at the conclusion, ECMO enables to markedly reduce mechanical ventilation. Actually, mechanical ventilation should target a reduction of the tidal volume lower than 4 ml per kilogram, driving pressure lower than 15, to decrease the plateau pressure lower than 25 centimeters of water, to decrease the respiratory rate, to further reduce ventilator-induced lung injury with sufficient PEEP to prevent lung derecruitment. There is still many questions for the future. What is the role of PEEP? Should we combine it with prone positioning? Should we promote spontaneous breathing? And clearly, it's going to be very interesting in the next years.